Today's topic is CMS final rule on chronic care management and how you can use it to increase your revenue. All right, let's kick off today's webinar. As I mentioned, we have Doug Swords. Welcome, Doug. Doug is with Azalea Health, where he's a co-founder and vice president of RCM. He's got extensive experience in RCM operations. Doug, how you doing?
I'm doing great. Hope everybody else is doing good.
And we have Julie Lincoln, implementation and training manager with Azalea Health. She also has an extensive background and knowledge in the healthcare industry and a lot of frontline work and practice with physician practices, helping them with their technology and industry challenges. Hello, Julie. How you doing?
Hi, I'm doing great. How's everyone?
All right. So today we're going to be covering, first of all, the CCM program, Chronic Care Management Program. Why is it important and what do we need to know about it? Especially, what does it mean for practices and why should they participate? How can they take advantage of the incentives? And how can an EHR help you to manage your CCM program? And what can you do to get started now? The program was effective January 1st this year, so you do need to find out how you can become involved in it. First of all, why is CCM important? What do you need to know about it? The new final rule focuses on reforms, and I'll let Doug take it from there to kind of explain what it's about and why you need to know about it.
Yeah, this really is a very important program, and I don't know if a lot of the providers out there understand its impact, but you've always heard, or I've always heard, how much chronic care drives up the cost of our healthcare in general and how much spending is dedicated to chronic, treating chronic diseases. But if you just look at the statistics, they say a third of our population has at least one chronic disease, and that over 80% of all healthcare spending goes towards chronic disease management. So naturally, what can we do to reduce that number, to reduce the spending? And the big problem has been the historical thinking of the payers, and especially CMS. They've always been of the mindset that this non-face-to-face work that's being done behind the scenes is being bundled into the office visit reimbursement, for example. And so it's been traditionally been, not looked at as something separately reimbursable or worth reimbursing. And the last few years, that kind of mindset has changed, and a big example of that was in 2013, CMS acknowledged that the additional work involved in managing a patient following a hospital discharge was not really being covered by the existing reimbursement. So they created the Transitional Care Management CPT code and actually started carving out reimbursement for that work that's being done, because a big thing is the folks being discharged from the hospital, that care being provided to make sure that they don't end up back in the hospital again. So that was kind of like the beginning, and so this is in a continuation of that. This is a step towards value-based reimbursement and a step away from fee-for-service, whereas fee-for-service has been traditionally for face-to-face visits. Value-based reimbursement is supposed to incentivize providers and physicians to do additional care above and beyond to keep them healthy and to keep them out of the hospital, keep them out of the urgent care centers, et cetera. So there's a big revenue opportunity here too. That's why it's important. It's a little different than the traditional fee-for-service, because if you're getting paid essentially once a month instead of per face-to-face encounter. But if you can understand the program, and that's what we're going to talk about today, and understand how to bill for it, especially primary care providers, could stand to make, a significant increase in revenue.
Thank
you. Even have on your slide.
I think also with the aging population, I don't want to stereotype, but we are going to see an increase in chronic conditions. So the number of patients who are going to have chronic conditions is going to increase, which is probably why it's a good time to get involved in the program.
Right. Now's the time, like you said. The baby boomer generation is getting older, and the population is getting older in general. So it's just a statistical fact that more folks are going to have more chronic conditions the older they get. So this is a really important program to address that, and it also incentivizes the physicians.
Okay, so we move on to the next. So this comes down to cost. What can you make from this program? Why should you participate in it?
Right. So that's the big thing I hear is like, why bother? So we've just got some key facts here. The potential revenue opportunity is there, and we talked about that. We're going to continue to talk about that. On your previous slide, you had an example of, even if you had 50 patients that you were able to identify in your practice that had 2 or more chronic conditions, you're looking at additional $25,000 in revenue. We've seen some graphs from MGMA and some other entities that have estimated that, an average family physician practice could see over $200,000 in additional annual revenue. And it all, again, depends on the size of the practice and your patient base. But, just to understand the program in general, and we're going to get into it in more detail, but you're roughly looking at $40 to $42 a month in reimbursement per patient. The patient will have co-insurance on that. Some other important information, Medicare Advantage plans are supposed to be participating in this too. The way it works with Medicare Advantage is supposed to have the same coverage reimbursement that regular Medicare. So from everything I've read, Medicare Advantage will also be reimbursing for CCM. One interesting thing I saw was that only, as far as who could bill for this, we're looking at mainly nurse practitioners, PAs, medical doctors, clinical nurse specialists, and certified midwives. They exclude licensed clinical social workers and PhD, which I found interesting. You cannot bill for and get reimbursed for CCM if you're already billing for transitional care management, home health care supervision, or certain end-stage renal disease services and hospice care supervision. So that was interesting. If you're already doing those or getting reimbursed for those, you may not also get reimbursed for CCM. CCM is not recognized as a rural health clinic service, which I also found interesting. CMS has not recognized it, and they say that they will not be reimbursed, that they're all inclusive of their per diem rate for CCM services. And it's kind of vague, but they say if they meet certain requirements to bill, mainly on a HCFA 1500 form, it might be possible, but it doesn't. It seems that for a majority of the RHCs are not going to qualify for additional reimbursement under this program. Another interesting fact about the program is that we're going to get into what constitutes 20 minutes of non-face-to-face, but that the actual non-face-to-face work can be done under general supervision. For those of you out there that understand the difference between general and direct supervision is when the physician or entity is in the same building, whereas general supervision simply means that the provider is available via phone call, but not necessarily in the building.
Good, thank you. That's good facts, good information. So what can people do to take advantage of the program? How do they get started?
So the main thing, if you want to look, take the high-level view, you've got to, the main components is you have to identify your patients that have at least 2 or more chronic conditions. And this is where your EHR vendor can come into play. But simply put, finding that list is the very first step in saying, like, how many do I have? So you may ask, well, what's a chronic condition, or is there a list of chronic conditions out there? And Medicare does have, if you Google chronic condition warehouse, you will find a list of 22 specific chronic conditions. But according to the CMS final rule, they are not saying that this is an all-inclusive list. So you could make a case for other chronic conditions outside of the ones listed in the chronic condition warehouse to use for this program. The second thing you need to do after you identify and create your list of patients that meet the criteria is to develop a consent form to be signed by the patient. And there's certain requirements that need to be on the consent form. Basically, what you need to do is notify the patient what the program is, make sure they're aware of the conditions of the program, and get their signature. So they've got to understand what the program is, that it's not for face-to-face visits, that only one provider can bill for this per patient. So the patient, by signing the consent form, then will acknowledge that that doctor is the only one that's going to be able to bill that monthly CCM rate, so they can't sign that at multiple offices. They're going to have to understand that their health information is going to be shared with other providers for proper care coordination purposes, and that the beneficiary can also stop or revoke their CCM at any time during any calendar month, and that, and then the last thing, which I think I already mentioned, is that they have to be made aware that they're going to owe like a co-insurance or a deductible, and I think the co-insurance is going to be roughly around $8 per month. So they need to know about that, and it won't affect. I know a lot of Medicare patients have supplemental plans, and they might have other secondary payers that might take that $8 up. So they would need to understand that as well. So in addition to having that consent form, have all that information, have it signed, and make sure you have it saved to their account, and then make sure that it's been documented in their account that they have actually signed that. So establish your list, get the consent form ready, be prepared to explain it to your patients that qualify and get their signature. And then during the month, you're required to qualify to bill and get paid. You have to provide at least 20 minutes or more of chronic care non-face-to-face management per month per patient. So what is chronic care by definition? And CMS says it's performing medication reconciliation, overseeing the beneficiary's self-management of medications, ensuring receipt of all recommended preventative services, monitoring the beneficiary's condition, physical, mental, and social. It's not all-inclusive. There's other things that can be included. And these non-face-to-face care management services can be furnished by licensed clinical staff, under general supervision, like I mentioned before, and that includes APRNs, PAs, RNs, licensed clinical social workers, LPNs. So some of the folks that can't bill for it directly can perform the non-face-to-face care management services under the supervision of an eligible provider. So I found that very interesting. You have to create the electronic care plan, of course, and provide 24/7 access to the patient. We're going to get into that more in a second, but using your EHR, you should be able to accomplish those things. And then finally, of course, is getting paid for it. So setting up a program, we're going to get into more about how to bill for this. You use CPT 99490, and I've actually seen there's a couple other CPT codes that are out there for CCM, but they're not currently recognized for reimbursement. This is the only one right now, 99490, that is recognized for reimbursement. So again, you can only get paid once per month for that. Only one provider can get paid for that per month. And let me share a couple other billing requirements. You don't automatically get it once a month. Tamara, that was one of the interesting things I saw too. So just because, like right now in January, you've identified a patient that's got 2 or more. If you're not providing 20 minutes or more of non-face-to-face per month, you don't automatically, so you can't bill. So you're going to have to be able to identify for every month and make sure that that 20 minutes of non-face-to-face has occurred. And that you wouldn't also bill. Yep, and another billing thing to keep in mind is that you would not also bill for this at the same time of a face-to-face visit. This is something billed outside of that. It's kind of similar to the Care Plan Oversight G0181 CPT code, where you're actually billing it for a month's worth of time. It's going to be similar.
That's interesting, though. I may want to add that to my notes. 2 quick notes on these 2 comments. First of all, I'll remind people that we do have a white paper on CCM available on our website. I'll also do a follow-up email to all the registrants, and I'll have a link to that white paper as well as a link to the CMS list of chronic conditions. All right, let's move on. Oops, here's my this. All right, so a question is, this is all that you have to do, but how can your EHR help you to manage once you're involved in the program? What are the benefits of having a certified EHR?
There's a few things to highlight here. You have to use a certified EHR. And what that means is that for 2015, for example, It's any EHR that satisfies either the 2011 or 2014 edition of the certification criteria for EHR incentive program. Basically, if that EHR has been meaningful use certified, it is a certified EHR for furnishing CCM. The provider must be able to transmit the summary of care record electronically for purposes of care coordination. The second thing is to maintain an electronic care plan. In your EHR, you should be able to document an electronic care plan based on physical, mental, cognitive, psychological, functional, and environmental assessments of the beneficiary's needs. That plan should include like an inventory of the resources and support, education, and it should address all the health issues, not just the chronic conditions, to be the requirement for the electronic care plan. The third thing is that to ensure the beneficiary has access to the care. Now this can be accomplished a few different ways. It depends on which EHR you use, but you have to provide the patient with 24/7 basic access. So like in Exelia, for example, you can give their care plan via the patient portal. So they can be enrolled in the patient portal and you can release that care plan to the patient portal and they have 24/7 access. They also have 24/7 access to the provider so they can message the provider if they need anything, and they have to be able to get in touch with that provider pretty easily. One way is through a secure messaging system to message the provider directly. What is required for beneficiary access? It's 24/7, and you must be able to get successive routine appointments with a designated practitioner or member of the care team. So this just basically means that you must have access to that provider pretty easily, or anybody in that provider's practice. Again, this can be done through a messaging system via the patient portal, or by phone calls 24/7. The fourth thing is to facilitate transitions of care and coordinate the care plan. This basically, again, is given 24/7 access to the care plan, and it just has to be furnished to the beneficiary.
Okay, Julie, I'm going to go on to the next slide because we discussed more on the next slide about the EHR, especially how the EHR can help with the plan and help our clients manage the CCM program.
Right. So, of course, we talked earlier about identifying these patients, so that's kind of easier said than done. So you're going to have to use your EHR system to identify who these folks are. So whether that's using your patient list and filtering or running a report, again, it all depends on what your EHR has. And, you know, you may need to reach out to your EHR vendor to ask them. They should be aware of what this program is and what you need. So that's the first thing, is finding that easily. So you're not going through every one of your patients one at a time. You don't want to do that. How do you also monitor? How do you set up your EHR to monitor this? So you can look back at your charts. How do you set up clinical alerts? There's different ways and different EMRs to alert yourself to record things. You know, from all the things that I've read, you know, they say, well, what do you need to have documented in case of an audit? So, and they said, well, it's not really clear at this point, but that just to make sure that anybody that's providing this non-face-to-face, that it's easily identifiable who they are in the chart. So if it is like a registered nurse, make sure that their name has been associated with a note. If it was just a note about a prescription that was followed up on, or if, you know, if they spend time reviewing the charts with another one of the patient's providers, make sure that that is easily identifiable somewhere in the chart. So that way it's not too time-consuming every month to go through your list of chronic condition patients and figuring out whether that 20 minutes of non-face-to-face was done. So that you really do need to leverage your EHR system for this to be an effective program. Again, talking about consent agreements, we already have one built in. We have a handout section of our system, for example. And, they may be called handouts in other systems where you could build in the template that has all the required information that the patient's going to need to see, the signature line, and all the other stuff that you need to have on that form to make it a legitimate form. And go ahead and have that built into the EHR and ready to go. Work that into your workflow of your practice as well. So, but you're going to have to make it easily pulled from the EHR system, so that way the staff is not having to fill the form out completely. And Azalea, you could set variables that'll pull the patient's name onto the form and other information, so all they would need to do is sign it. You could probably even associate a digital signature with it if your EHR has a digital signature capability. Anything that would reduce the amount of time you would have to spend interacting with the patient about the program, so that way it's not disrupting your workflow too much, because that is kind of one of the things that we do hear from some of our providers, that they're kind of hesitant to get started because they think it's going to be a disruption of their workflow maybe, and that it may not be worth the effort.
Right.
Oh, and then of course billing. We talked about the requirements. Hey, you can only bill it once per month per provider or per patient, and that no two providers. But you also have to, with it being a non-traditional type of billing code, it's not something that's triggered by face-to-face events. So the billing staff may not have a handle on it at the beginning. So they're going to have to practice, set reminders, make sure they can use the EHR to identify these for the biller, not just the clinical staff, so that the billers can identify it, make sure that they're getting them billed out on time and for the right people, and then they're not billing them for people that, because like I said, you can't bill this every month automatically. You have to make sure that that 20 minutes of non-face-to-face took place, and so the billers need to be aware of that as well, and they need to be able to know when to bill it and for who. And the EHR is the only way they're going to be able to identify that.
Right, and it's going to take coordination between providers, I think, to make sure that they're not overlapping. Only one person can claim it.
Right, and it's funny when you read through this stuff, it sounds like a lot, but really, I mean, the way I like to put it is, Medicare, they've come up with a way that they're reimbursing the doctors for what they're already doing.
Right.
So you're not really having to go too far out of your way. It's just making sure, if you're using a meaningful use certified EHR, you're probably already doing these things. Just making sure they're documented properly so you can bill for it.
And this is packaging it, putting it into a program where you can realize some pretty nice incentive from it once you have it up and going. Yeah.
They put this together they're trying to, take a step towards that value-based reimbursement. So they're not wanting this to be difficult, like PQRS difficult or meaningful use difficult. They're trying to make this one an easy one. But of course, Medicare never makes anything that easy. So that's why we're having a webinar to kind of talk about it.
Right. Just want to remind people quickly again, we do have a white paper on this on our website. The white paper does also include a sample patient consent form. Moving on, we're opening up the floor now to questions from our audience. You can enter them into the chat box here. I'll take your questions. Oops, I don't know why I did that. Okay, I've got a couple of questions coming in. Doug, you ready?
I'm ready.
Okay, and we've heard this one before, and it's a general concern is, isn't this too time-consuming to staff to implement and track? Track this type of care plan.
I had a feeling. I've talked to providers just in like networking events and social settings and said, hey, you're going to take advantage of this, because especially primary care doctors, and one of the first things I hear is, oh, it's going to be more trouble than it's worth. That $40 is not going to be worth the amount of time that we're going to have to train our staff, and it's because it may on the surface, when they talk about you got to create an electronic care plan, you got to do this, it's going to have this in it. It seems like you're having to do that in addition to what you're doing now, but I look at it as a wink-wink from Medicare. They're like, look, if you're already doing this, especially if you're testing for meaningful use, this is already happening. So just make sure you're documenting it enough to where even the wording says reasonably be assured that 20 minutes. It doesn't have to be like listed like from 10:30 to 10:25 every day. I reviewed the chart. They just have to be reasonably assured that it's taking place. And the biggest, really, the disruptor of the workflow, in my opinion, is the consent form, and making sure that you take the time to explain that to the patient during the registration as they're coming into the practice. I think that, if you could come up with a good system because you're not going to explain that to everybody that walks in the door, just the folks that meet the requirements. So.
Right. Okay, Doug, I've got a number of questions coming in. Good questions. I think we're getting a lot of interest from folks out there. Okay, how many patients a month would this apply to?
So it would be unlimited as long as they met the
I was going to say, I haven't seen any limit indicators in anything I've read.
No, I mean, it's just making sure, it's only for Medicare and Medicare Advantage, so you wouldn't be able to bill this right now for a commercial patient. So if you have 200 patients a month that you're managing chronic, then you could bill for that CPT code for all 20 of them and get paid, whatever $42 times 200 is a month.
Okay. Another good question here. What DOS should be on the claim? Do you wait for 30 days to pass and then bill 99490 after 30 days with the last day of the month as the DOS?
That's a good question, and I haven't seen definitively, but I would imagine, and I mentioned G0181, the home health supervision code before, because that's a unique code in that for the date of service, you actually put a range, and you're not putting the same date from and to. So usually for an E&M code, the date of service from date and the to date are the same day. But for the general, that supervision home health, you actually put the first day of the month as the from date, and the last day of the month is the to date. So I would, and I don't know this 100% for sure, but I would imagine that's how you bill for it. And I haven't been able to find out if you have to bill it within the month or if you could bill it right after the month ends. I would imagine you would want to wait until the month ended so you could look back and see. So I'm pretty sure that you could, it wouldn't have to be billed out within the same month for that month. So like February 1st, for example, you should be able to bill for January.
Okay, thank you, Doug. And I think there may be more information available on CMS. I'll see if I can find some access to that and follow up on that. 24/7 access to provider. Is this access to the provider team?
Yeah, so, and that's also kind of loosely defined.
Yeah.
24/7 access to the care plan and to the provider team. So even some of the stuff that I've read, that there's companies now that are coming out that if you wanted to have like after-hour phone number available, you could outsource that. So you don't actually have to have somebody on staff on call every night. The big piece of it, and Julie, correct me if I'm wrong, is making sure that, and again, that's why they want you to be using Meaningful Use certified product, that you can make it available 24/7 through a web connection. So the patient can get online and see it in the middle of the night if they want to.
Yes, so they have to just, like in Azalea, they just release it to the patient portal, and then that patient has access to their care plan. But then the provider must also just be reachable 24/7, which we would recommend in Azalea using the secure messaging system to message the provider.
Great, thank you. Okay, another good question. We are FQHC. Will this bundle into our encounter cost, or is this a service we should bill FFS?
Well, Medicare is not currently, they've come out and said they're not for FQHCs and RHCs, are not going to separately reimburse for this unless you meet certain requirements. And if you go to the CMS website, they will list what those requirements are. And if you did meet the requirements, you would bill it on a HCFA 1500 outside of the usual process, which I believe involves a UB04 claim. So I would check and I think if you Google CCM, FQHC, applicable requirements, you'll be able to find a list of what would qualify you to bill for this outside of what you already get for your FQHC reimbursement.
Thanks. Okay. If a patient doesn't wish to have this done every month, but every other month or few months, is that okay to bill every couple of months?
I guess, and I can see this coming up too, where the patient, you know, especially if they don't have a supplemental plan and they are going to be paying that $8 out of pocket, you might get some pushback. And so I suppose it's up to the practice to say, well, sure, we'll make, you know, a note on your account, or we'll flag you to only bill it every other month. I would imagine that's up to the provider's discretion. I mean, they could technically bill for it every month in which they meet the criteria, but I don't think Medicare would come down on a provider for skipping a month at the patient's request.
Right. Okay, thanks for that. Let's see, a couple others. Don't you think it would be too cumbersome to set up a process to explain the program and obtain waiver signatures from the patients? So essentially the whole patient consent form, do you see that's going to be an issue?
I think that of all the things in this program, that would be the hardest one. I've heard some of the other providers talk about the care plan, but the care plan itself, I think, is already happening in your EHR. It's the consent form. I think if you were to sit down and come up with a good plan, have the form ready, have even a script typed out of how to explain it, and go over that with your staff and make sure that you've identified those patients and tell your staff, okay, you only need to be concerned with this for the following patients, and then have a mechanism in the EHR where they can know, okay, I've got 20 patients coming in today, for example, and 2 of them meet this condition. They're Medicare patients, but 2 or more. I'll have a reminder set up to have my script ready, and I'm going to go through the script with the patient and offer them the consent form. And if you could go ahead and put those things in place in advance, the actual process of explaining it to the patient and asking for the signature hopefully wouldn't take more than a couple of minutes.
And the consent form is not very extensive. It's 1 page, pretty easy to answer.
Exactly. It's, hey, this is what this is. We're doing a chronic care management. It's a Medicare program. It's for non-face-to-face. It's for all the stuff we do outside of your visits. And you may have an $8 co-insurance. I mean, that's the gist of it, making sure they understand that.
Right. A couple of comments. The biggest question was, is this presentation going to be available? We are recording this presentation, and it will be available on our website, the recording of it, probably early next week. If you'd like a copy of the PowerPoint, send an email to marketing@azaleahealth.com. And I want to remind everybody we do have a white paper also available. I'll be sending out an email to all registrants with links to the webinar and to the white paper. And I want to remind you that next month our topic is on Azalea Health pre-cert services, and that's going to be February 12th. We'll have a link in the email follow-up as well to register for that. I want to thank our panelists today, Doug Swords and Julie Lincoln. You guys have been great, very knowledgeable. Appreciate your helping share your knowledge on chronic care management program. Any final comments?
We enjoyed it. We wish everyone the best of luck implementing their CCM programs.
Great. Thank you, and have a good day.